I have a wonderful history with Dr. Kuenzler. She was actually one of my original clinic preceptors back in my training, and then she became one of my main teaching faculty in fellowship, and now I get to call her a colleague, and we spend some time Thursday afternoons in the EMG lab. So she's here to talk to us about ALS, something we haven't talked about in a while. There's been some good and not so good updates in the ALS field recently, but overall, it's a diagnosis that we need to know about and something that we need to be able to treat, as these patients obviously have a very big demand and need for their neurologist to be aware and up to date. And so without further ado, please welcome Dr. Kuenzler.
Well, thank you for reminding me of how long we've known each other. That was really helpful. I had forgotten that we were an outpatient clinic. Yeah, Marquardt Kuenzler Clinic. Okay. Well, I'm glad everyone is sticking with us through the afternoon here for more talk about neurodegeneration. We got some of that this morning, and I think that each speaker is making a similar comment toward the beginning of their discussion that, this could be a whole weekend just about each topic. And that's very true in ALS, certainly, as well as some of these other topics that we've been reviewing. We're going to try to get through some sort of basic information about ALS, the presentation that you're going to see in the clinic, how we're getting to that diagnosis, what we do or maybe don't understand about the pathophysiology of ALS, treatment options, both disease-modifying therapy and then management strategies, as well as some ongoing research. So the initial presentation, for those of us who've been through the neurology board exam, the progressive painless weakness is really the thing that you end up seeing as the most common presentation. So the spinal onset type of ALS with foot drop or hand weakness, certainly can be proximal muscles, shoulder or proximal leg or anything like that. But that progressive painless weakness is most frequently what you're going to end up seeing coming into your clinic. About 25% of patients who are first developing ALS-related symptoms will start with bulbar onset. So their dysarthria and dysphagia as their primary symptoms. There are some patients who come in with mostly spasticity, patients who come in with mostly shortness of breath, but those are relatively rare. We do see them, but not very often. And of course, there's the mix of upper and lower motor neuron, and that's the main thing that we're trying to tease out when we're doing an initial examination of these patients. The upper motor neuron and lower motor neuron will both have that feature of weakness, but it's going to look very different when you're checking the examination. Is it spastic for the upper motor neuron component? Is it flaccid for the lower motor neuron component? Are the reflexes up or down? We do end up doing some additional maneuvers when we're thinking about ALS in a patient. I don't know about you, but in my patients with tingling in their toes who are coming for neuropathy, I don't necessarily look for jaw jerk and facial reflexes. I don't look for tongue atrophy and fasciculations. I'm not doing sustained observation of the arms and legs looking for fasciculation. So there are going to be a few additional examination pieces that we need to be considering adding when we have a patient who's coming in with a progressive painless weakness. And I think most of us as a first step would send these folks for an EMG. What we would anticipate seeing on the EMG is that the sensory responses are going to be normal. The motor responses will often be low, not always, sort of depending on what body parts are affected or not. And then on needle examination, we're looking for active on chronic motor axon loss changes. And when we're doing these examinations, we want to make sure that we're looking at multiple segments. So, for example, in our EMG lab, a typical ALS protocol EMG, we're looking at both an arm and a leg for both nerve conductions and for needle electrode examination, as well as always including needle electrode examination of thoracic paraspinal muscles. We may or may not do needle examination of bulbar muscles. It sort of depends on the individual patient, but especially someone who's coming in with dysarthria, dysphagia as initial presenting symptoms, you're going to want to make sure that you add some muscles. The tongue, mentalis, sternocleidomastoid can be helpful. So orbicularis oris, there are a number of different muscles that can be checked on EMG to look for that lower motor neuron component of things. We're also assessing for fasciculation potentials, making sure that we're pausing during spontaneous activity assessment on the EMG and looking for those fasciculations, giving them a little time to develop. One of the patterns that we can look for on an EMG is what's called the split hand. So the split hand is where the sort of thenar side of the hand, the thenar eminence, and the first dorsal interosseous are more affected, and the abductor digiti minimi, the hypothenar, is less affected. So you start to see this split, even though they all come from a similar nerve root distribution. You've got ulnar nerve overlap and some of those muscles coming from the same nerve and root distribution, but you still see that split in terms of how the patient's examination turns out. So this is a table that I think most residents who have been through my clinic have had the pleasure of reviewing with me. It's a pretty busy slide, but I think it's a helpful way to think about how we consider the differential diagnosis for these patients. ALS is certainly a difficult diagnosis to be confident of, especially if it's not something that you see on a regular basis, but having some basis for considering what to look for with upper motor neuron predominant presentations, lower motor neuron predominant can be helpful. So really in all patients, there's sort of a typical set of labs that we're going to check, kind of basic things, the CBC, the CMP. We're going to check the thyroid functions. We'll look at B12. We'll also be looking for the immunofixation to make sure there isn't a monoclonal gammopathy as a reason behind things. For folks who have a family history, we certainly would want to offer genetic testing, and we'll talk a little bit more about that as we're going through. So that's, I think, become a more important part of the care that we're offering. You'll notice that there are a whole lot of conditions listed here that may or may not really match the clinical presentation that you're seeing. You know, I can't remember the last person that I really thought had porphyria. Ben Clater, I apologize. I know you're a big fan of porphyria, but I think that there are a lot of different conditions that maybe have a little overlap with what we see in ALS, but overall we're less suspicious of them. Still want to try to rule them out. I would say that in someone who's got some history of inflammatory rheumatologic kinds of conditions, investigating that a little bit further, make sure that's not a reason for the symptoms that are developing. I almost always check Lyme disease in these patients, because even if they're not saying anything on the first visit, 6 months, 12 months later, someone asks them if maybe it's Lyme disease and not ALS. It's happened too often, so I just always check Lyme disease on these patients. I've yet to find one that's positive. Looking for infections, syphilis, HTLV, and just kind of thinking through whether there are risk factors for lead or mercury poisoning. Are there reasons you should be thinking about a neuromuscular junction or myopathy disorder as the etiology, just to kind of think through those possibilities. Then the other thing down here is talking about other non-laboratory kinds of things to consider. So mostly thinking about imaging kinds of studies. So looking at MRI scans to rule out brainstem pathology, high cervical cord lesions, multifocal radiculopathies as reasons why people might have the clinical presentation that you're seeing. So the ALS Association has this tool that's available online. I wish it were interactive. It's not. They're working on it. But the idea is that if you have a patient where you're considering ALS as a reason for their symptoms, this Think ALS tool can be helpful in just framing what information you have about the patient to decide whether you should be going down this ALS path. So if you have someone who has progressive asymmetrical weakness and they don't have pain, they don't have sensory loss, then your antennae are really up for something in the ALS family or the motor neuron disease family. So then this tool is kind of listing things that would make you think that it does fall into this category: the weakness, atrophy, fasciculations, dysphagia, sort of depending on the area of presentation, other things that are supportive for family history, other exam findings that could be supportive of the diagnosis, and then things that would make you think it's less likely. So if they do have pain, if they have Parkinsonian features like cogwheel rigidity, if there are a lot of sensory symptoms as a part of their presentation, then those are going to make you think it's less likely. Generally, this Think ALS tool doesn't really tell you a whole lot about where to go with that information other than just saying, oh, they should see someone who knows how to diagnose ALS. But at least it gives you some framework for thinking about how to decide whether that's a path that you should be following for the patient that's in front of you. Okay, we're going to do a self-assessment question. I tried to avoid the accept questions that some of my colleagues were talking about, and instead it just ended up being a lot of words. So if we're thinking about factors that would increase the risk of developing ALS, so the first option, lead exposure, male gender, high body mass index. Second option, higher education levels, head injury, caffeine consumption. Option C, lead exposure, head injury, male gender. Or option D, formaldehyde exposure, limited physical activity levels, and alcohol consumption. All right, I think we did pretty well there. All right, so, oops. There we are. Okay, so agreed. Lead exposure, head injury, male gender, those are all things that are going to make us more concerned. So there have been a bunch of different studies looking at this very issue because it certainly does seem like there are some common threads that seem to run through some of the patients that we see. Things that we know are potentially increasing risk for patients. So men more than women, absolutely. People who have elevated LDL, that's a little bit makes me a little nervous. Smoking, but apparently only for women, not for men. So sorry, ladies. Physical activity levels, so being high physical activity, having a very low BMI. Military service is actually another one that's come up. That's one of the reasons that from the perspective of the Veterans Administration, ALS is considered a service associated condition, and patients who are affiliated with the VA have a lot of benefits that come through that, which is sort of a positive or a negative depending on how you look at it. We don't really know why it is that people who have that military service background seem to be more prone to developing ALS. There are thoughts about high activity levels. There are thoughts about different chemical exposures. Is it vaccination exposure? It's a little bit unclear. But it's, things like head injuries, there are some things that seem like they might have some overlap with that military population. Even in the non-military population, there's certainly toxic exposures, and this is another area of ongoing research trying to figure out what are some of these different exposures or environmental factors that might be reasons for people to be more prone to developing ALS. And head injuries is definitely one that's on the list. I did make a special note over to the side that there's not an increased risk with caffeine or alcohol use, so you can all feel a little bit better about the coffee you had this morning and the alcohol you might have at the restaurant tonight. So as a part of trying to figure out what the underlying causative factors might be, or risk factors might be for developing ALS, the CDC put together this national ALS registry. It's been about 7 years now, something along those lines. And literally you can just go online, Google CDC ALS, and their website comes up. There are a couple of different components to this. Patients can sign up and do a number of different things. There are a number of surveys, sort of demographic surveys, occupational surveys, different habits. They have an option for tracking disease progression through questionnaires, as well as donating samples. So that can be blood, saliva, and urine. They have this national ALS biorepository that can be used by researchers. So both the surveys and the samples can be accessed if you go through the CDC and put in a proposal. They can allow you access to the data and to the biologic specimens, which is another option for ongoing research into ALS and causation. So genetic testing is something that's really been evolving over the last decade. Familial ALS accounts for about 10 to 20% of ALS, but about 5 to 10% of people who don't have a family history will have a mutation in one of the genes. The most common of those is the C9 open reading frame 72. We'll talk a little bit more about that gene later on. It's at the point now where really offering genetic testing is considered in ALS circles to be a standard of care. There are a lot of personal decisions that might lead someone to want to do genetic testing or not. So it's something that we offer to all our patients. One of the positives is that there are options for no-cost testing. A company called Invitae has a Biogen-sponsored panel of genes, and Prevention Genetics has Ionis-sponsored genetic testing available. Invitae just got bought by LabCorp, but we're being told that that's not going to change anything. Hopefully that's going to be true. And on the more positive side, if you have a patient who's diagnosed with ALS, what are the things that would portend a better prognosis? So male gender, folks who are male tend to do a little bit better. People who have spinal onset as opposed to bulbar onset symptoms. Folks who are younger, so our 50-year-olds rather than our 80-year-olds. A longer diagnostic delay, we think that that's because if it takes you longer to get to the diagnosis, probably it's because the disease is changing more slowly. So that's what the research has shown so far. So it can be a bit of a plus or minus when it takes a patient a little bit longer to be able to get to the point of an ALS diagnosis. Having a higher baseline body mass index and weight stability when they're sort of early in their disease course are actually positives. And we know that people who attend multidisciplinary clinics are going to have a better prognosis just having access to additional resources and care. Okay, so let's talk about pathophysiology. So whenever you see a list of potential mechanisms like this, the first thing that should probably come into your head is these people have no idea what's going on. And that would be true. We have no idea what's going on. There are a lot of theories out there about what the underlying cause is for ALS, and no one really has been able to develop a unifying theory for the underlying etiology. So we end up with a list like this for potential mechanisms. And we end up with slides like this that are looking at different cell parts and, is this related to the oligodendrocyte somehow being dysfunctional? Is this related to something that's within the nucleus? Is there something in the endoplasmic reticulum? Is it a DNA repair problem? Is it an axonal transport problem? Is it excitotoxicity? We have a lot of thoughts about what the underlying etiologies might be, but it's really unclear at this point what the unifying factor is. Whenever we're in that situation and we have different genes that we can look at, then the question becomes, can those genes teach us anything about what the underlying cause might be? So we'll talk through a few of these different genes and what we're learning. I don't know that it's really going to clarify the pathophysiology for you, but at least we'll talk about it a little bit. So superoxide dismutase 1, SOD1, so this is the original gene. And this is a metalloenzyme that binds copper and zinc, and it's both in the cytosol and in the membrane. It's an antioxidant, basically, so it catalyzes the oxygen and hydrogen peroxide from the superoxide species. There are a bunch of different mutations, mostly missense mutations, a bunch of variants that can end up causing ALS. And depending on what the specific mutation is, that can alter the phenotype and the duration of the disease. So when we try to look into this a little bit, the first question is whether this is a loss of function or a gain of function. So they looked into loss of function, and looks like it's not really that. So decreased enzyme activity doesn't seem to correlate with causing disease. Okay, well, what about if you completely knock it out? Knockout mice didn't show any kind of problem with the ALS phenotype, so maybe it's gain of function. But it still isn't quite clear what that is. So is it excitotoxicity? Is there a mitochondrial dysfunction? Still a lot of questions about what the underlying reason is that the SOD mutations cause the pathophysiology that they do, or cause the clinical pathology that we see. We heard a little bit about TDP-43 earlier this morning, and so this is a specific protein that we can see building up. We talked about that being an issue in our movement disorders patients as well. We can see that in sporadic ALS. And so the TDP-43 is a regulator of gene expression and RNA processing. So it's shuttling between the nucleus and the cytoplasm. And the familial ALS mutations are mostly in the glycine-rich region of the carboxy terminal. So it seems to be in pre-mRNA splicing. So yet again, it's not clear whether this is loss of function, gain of function, or both. It does seem like overexpression in mouse models is more likely to cause the neurodegeneration, so probably some relationship there. So this graphic is just trying to show that if you have sort of normal TDP regulation, TDP43 regulation, then you have sort of a typical breakdown of some of the mRNA, whereas if it's misregulated, then you have buildup of these TDP43 proteins, and that's part of what we can see on pathology. So C9 open frame 72 is another one where the initial question was gain of function versus loss of function, but knockout and knockdown mice unaffected. So it looks like it's a gain of function problem. And once again, it's not really clear what it's doing. Lots of theories about RNA misprocessing and maybe sequestering some of the RNA binding proteins and impairing their function, but still unclear what the underlying reasons are. Oh, that's right. And then I saw that there is, okay. So got some of the slides mixed up. I apologize. So the C9 open reading frame 72 is a hexanucleotide repeat. A normal individual will have 5 to 10 repeats. ALS patients can have thousands. And so what we think is that there's this gain of function that leads to this sequestering of the RNA binding proteins or some sort of issue with the nucleocytoplasmic transport. And there we go. Another gene that we see in some of our patients, and unfortunately in early onset and juvenile cases, is the fusion sarcoma gene, which is another RNA binding protein, and seems to have a role in DNA repair. And once again, it seems like it's more of a gain of function mutation because the overexpression in mice seems to lead to a severe motor neuron disease phenotype. And the thought is that cytoplasmic aggregates can cause splicing defects and DNA damage. Okay, so basically what we know is that we don't know enough to know what we're doing with these ALS patients. So when we're thinking about disease-modifying therapy, it's been a challenge to try to figure out what the ideal strategy will be. Is it going to be some sort of combination therapy? Is it going to need to be very individualized based on maybe some sort of biomarker that we haven't quite worked out yet? There's a lot of discussion and research going into that very topic. In terms of what we actually have available right now, riluzole, of course, is the one that's been around since the 90s. The general idea is that we think it inhibits glutamate release and that reduces this glutamate excitotoxicity. When you look back at the study that originally led to the approval of the medication, it improved ventilator-free survival by 3 months, which is not really a fantastic data point to offer to patients who are getting a devastating diagnosis like this. There have been some follow-up studies that are looking at patients on riluzole versus not on riluzole with kind of more modern treatment strategies. We've come a long way when it comes to knowing how to manage these patients in the last 25 years. And so database reviews would suggest that maybe the benefit is a longer prolongation of survival, 6 months in some. There's even one that shows up to 20 months or 21 months prolonged survival. The issue with that, of course, is that this is retrospective, and there's not really a way to control for patients self-selecting into the riluzole versus not riluzole group. Maybe the people who choose riluzole are more likely to choose other interventions, like deciding to get a feeding tube or deciding to use ventilatory support. So I think it's challenging to know what the real data is. There are concerns for hepatotoxicity and neutropenia. That's pretty rare. The original study said in 10% of patients. It seems like it's less than that according to the patients that I follow, but we still monitor LFTs and CBCs. It's sort of an annoying medication to take because protein interferes with uptake. And so patients are supposed to take it separate from food, either half an hour before or 2 hours after, which can be kind of annoying. Most common side effects are GI upset and dizziness. Then edaravone came along, in the I don't remember the year. Anyway, in the late 2010s, and this is Radicava. Started off as an IV, and then an oral liquid was approved in 2022. This is a free radical scavenger, basically. Sort of an interesting medication that started off life in Japan as an acute stroke intervention. They were trying to reduce the ischemic penumbra in patients. And then didn't really get much traction with that and started looking into a variety of neurodegenerative diseases to see whether they could show that it had some benefit there. And so it's the study that led to approval had pretty restrictive inclusion criteria. So people had to be less than 2 years of disease. Their breathing still had to be quite good, greater than 80% of normal for FVC. There were a bunch of different things that made it a very difficult study to get into. So they were kind of cherry picking, in my opinion, the patients that were going into this study. And it did show a benefit in patients who were on versus off the medication. That's not been duplicated in patients with sort of a broader patient population. So it's difficult to know for the patient who's in front of you what the benefit might be for this medication. Generally, in terms of the benefit, it seemed to be pretty similar to riluzole, about a 3-month difference in survival. They calculated it a little bit differently, but roughly it seems to be pretty similar. The dosing is a little bit weird. So you take the medication every day for 2 weeks to start. Then you take a 2-week drug vacation. And after that, it's 10 out of 14 days. So basically Monday through Friday, 2 weeks on, 2 weeks off. And that's how you continue on the medication. They actually tried a study with taking the medication daily at a different dose, and it didn't work. So I don't know what that means, but this is a medication that's available, but not necessarily high on the list for a lot of ALS providers. Okay, then we got the big red X. So sodium phenylbutyrate torsadilol, also known as Relivrio here in the US, Albriova in Canada, is a medication that was approved in the US a few years back based on phase 2 trial data. There was a phase 3 that was still going because the European regulators were requiring a phase 3 trial be completed before they would allow the medication to come up for approval there. So it became available in the US and Canada, and then the phase 3 trial came out and it was negative. So that medication has been pulled off the market. That happened early this year, and so it's not currently available. But I think it was sort of an interesting lesson for the ALS community about how much we can truly rely on some of this phase 2 data, even if it looks very positive. And it's a tricky balance because patients want to have options for their care. Okay, so before we talk about our next medication, we're going to be talking about tofersen. So the presumed mechanism of tofersen is A, reduced synaptic availability of glutamate, B, antisense oligonucleotide binding of SOD1 mRNA, C, reduced neuronal apoptosis via reduced mitochondrial stress, and D, antioxidant reducing free radicals. I'll give it a minute here. Okay, so answer B is correct. So this is kind of the new frontier when it comes to these inherited conditions. So tofersen is a medication that is intended for use in patients with SOD1, and it is an intrathecally administered, remember intrathecally, antisense oligonucleotide, and it reduces the synthesis of SOD1 protein by inducing the degradation of the messenger RNA. So the brand name for this medication is called Sodi. So it was just approved a little over a year ago. So it's given every 2 weeks as an intrathecal injection for the first 3 doses, and then once a month, so every 28 days. This is another sort of interesting lesson in how a medication came to get approved. This particular study did not show that there was a slowing of the progression of ALS. It did not slow the disease in people on versus not on the medication. What it did show is that there was reduced CSF SOD1, and there was a reduction in the neurofilament light chain in the spinal fluid and in the plasma. And those two biomarkers were adequate from the FDA perspective for the medication to be approved. So it's been an interesting journey getting to that approval, and it's going to be even more interesting as things move forward. There's going to be ongoing work to sort of figure out what's happening from that clinical perspective to make sure that we're offering a medication that truly alters clinical outcomes. Another thing that's going on is there's a study that's offering pre-symptomatic treatment. So for family members of patients who have known SOD1 mutation, they can get a monthly intrathecal injection. They're limiting the SOD1 patients to specific variants that tend to have a faster developing subtype just based on the variant of the SOD1 mutation. So it's not entirely clear. We think in about 2-3 years we're going to have some data coming out from that, but it's going to be an interesting story as that unfolds. Another thing that is available but is prescription but not offered through typical pharmacies, ultra high dose B12. So we're talking 50 milligrams of an IM injection twice a week. So this is an incredibly high dose. This is based on a trial where they looked at over 16 weeks patients. They looked at a variety of patients. Those within 1 year of onset seemed to have a slowing of their reduction in their ALS-FRS functional rating scale score. And it's a relatively benign thing as long as you don't mind being injected twice a week by someone in your family. Main side effect is pink or red urine. Based on the patients that I have who are using this, it is also not the most comfortable thing. It can be painful, especially folks who've got sort of atrophic muscles. Because it's sort of an atypical dose of a known medication, it's not covered by insurance. It's considered a supplement. It doesn't have any kind of special FDA approval, so insurance won't cover it. It requires a compounding pharmacy. So compounding pharmacies are a little few and far between. The ones near us, we kind of have relationships with them and know who's going to be able to do this for our patients. But especially for folks who are coming from out of state, that can be a little bit more challenging. So this is an option that's available. A lot of patients do want to try it just because it's a reasonably benign option. And if we're able to slow their progression, then they generally view that as a positive. In terms of cost for this medication, because it is entirely out of pocket, it's been a little bit variable. I've had some pharmacies that'll do it for $75. The family has to sort of draw it up themselves. Others will do pre-filled syringes, and that'll be about $150. We found another pharmacy for a patient because they were further away, and they wanted $300 a month. So it's not ridiculously expensive, but when you've got a condition like this, $300 a month is a lot. Then there are sort of non-standard treatment options. So stem cells are definitely out there, and patients, I think, hear a lot about stem cell therapy and what that could mean for a bunch of different neurodegenerative conditions. If you ever look at the website for some of these places, the plastic surgeon who will take your fat cells and turn them into stem cells and give you an IV, the number of conditions that they list is pretty phenomenal. So these are generally at-profit centers. This is an out-of-pocket cost for patients. The protocols that are currently available to patients are not FDA approved, obviously. And so those are something that patients are sometimes interested in, and we have to have pretty frank conversations about what the odds are that their adipose tissue getting turned into stem cells and being put in an IV is going to change something about their central nervous system or peripheral nervous system. So that's something that I have to watch out for my patients. Another resource for people who are very interested in sort of non-standard therapies is this group called ALS Untangled. So this is a group of ALS providers who will take suggestions from patients and do reviews of a bunch of different things. They have reviews on B12. They have reviews on other vitamin regimens. They have reviews on bee venom. They have healing therapy by a specific doctor. There are all kinds of reviews on there. Ashwagandha's on there. There's all kinds of stuff on this website. But they try to be very methodical about looking at what do we think we understand about the potential mechanisms, what are the reasons that we think that this could work, what's the actual data that's available, and then give actually a letter grade score. for these folks, so that you can at least offer patients something where they can try to look at an objective review of some of these different treatment options that are out there. In terms of the supplements that we typically recommend, so we do talk with patients about the ultra-high dose B12. The other supplements that I generally discuss with my patients are the acylcarnitine, L-serine, vitamin D, and then a specific compound called Basis, which is from a company called Elysium. So generally speaking, these are antioxidant types of supplements. So, oxidative stress, mitochondrial function. The L-serine is actually based on the specific chemical that the ALS, Parkinson's disease of Guam folks seem to have an increased BMAA, which I've forgotten what that stands for, but this chemical in their system, and that this L-serine seemed to reduce that chemical. So that's part of what that's based on. And so these are just other supplements that we offer patients. In terms of management, I don't know why it looks like that. So in terms of management options, there are a lot of different symptoms that we end up trying to address for patients. I'm going to see if I can move. Nope. So people will often talk about excess saliva. So we offer them things like atropine drops, other things to dry their mouth like amitriptyline. Glycopyrrolate is an option, but the glycopyrrolate, often people will complain that it makes their saliva more thick, which can be difficult when you have difficulty moving it around in your mouth. We can even go to salivary gland irradiation or Botox, and suction machines can be another management strategy. Oh, well, how about that? Okay. Well, I guess we knew what was up next, dysarthria. So, speech therapists can be really helpful for getting patients to work on techniques for increasing intelligibility and sort of talk through options for communication, especially as they have worsening of dysarthria over time. One of the things that I think some patients run into with speech therapists who have less exposure to working with ALS patients is the speech therapists really want them to exercise their tongue, and that just fatigues their tongue, and then they can't talk as clearly later on in the day. So I think, for a speech therapist who's used to working with a stroke patient, this is a very different kind of condition, and we just need to be a little thoughtful about the speech therapy regimens that we're signing off on, and making sure that we're not allowing our patients to get sort of burdened with a bunch of exercises that are just going to fatigue them. PEG tube is another big issue. Patients have a pretty big decision to make when they are choosing whether they want to move forward with a PEG tube. This graphic here is from the ALS guide, or the AAN guidelines for care of ALS patients, and basically just thinking about introducing the idea of PEG early because we want the FVC to be greater than 50%. That's going to decrease their risk of the procedure. And I've got like 3 minutes, so I'm going to try to go through a few more things. Spasticity, we've all had to deal with this before, I would imagine. Baclofen, tizanidine, pretty rare that we end up doing an intrathecal baclofen pump or Botox, but those are potential options as well. Mixilotine is actually really good for cramping. There was a study that showed a 70% reduction in cramping. They didn't include any patients who had arrhythmias at baseline, so that is a little bit of a limitation, but for a lot of patients, this can be really remarkably helpful when they've got problematic cramping or they're waking up at night from cramping. Magnesium can sometimes help. Tonic water, we used to prescribe quinine, but now you can only get that if you've got malaria. And so tonic water also sometimes can be helpful. For dyspnea, we're monitoring their bedside spirometry, doing formal pulmonary function tests. There are protocols for expiratory muscle strength training. So it's a special, kind of looks like a pickle device that you breathe into against a valve. And that's been shown to help maintain the FVC for a little bit longer. Also seems to help with preserving swallowing function. Cough assist devices can be helpful when it comes to clearing some of the secretions when you've got that shortness of breath, and then mucolytics can be helpful as well. So this is another graphic from the AAN guidelines, just talking about thinking through when you would want to start a device like a BiPAP on a patient. Insurance will cover it if your maximum inspiratory pressure is less than 60 centimeters of water, and or if you have an FVC of less than 50%. So those are kind of the numbers that I'm looking for in the pulmonary function tests that I'm getting on patients to see if we can get that covered. Okay. For patients who are interested, or providers as well, who are interested in looking at different ongoing research trials, this ALS Signal is actually a really great resource. You can kind of see on here, this is just a screenshot, where you can look at different countries. It targets the US and Canada. You can select a state, and then it'll show you what studies are available in a particular state. If there's a certain drug that you've heard about and you want to see where that's available in terms of clinical trials that are ongoing, what phase, certain genes. So this is actually a helpful tool for patients to try to look for studies that might be ongoing near them. There are a lot of things going on in terms of research. In the last 5 seconds, I will tell you that. So there are natural history kinds of studies. We're tracking patients and family members over time, looking at risk factors like that CDC registry. There's another sort of registry kind of thing coming through called All ALS. It's going to be across the country, a bunch of different centers, 50-some centers involved in that, looking at biomarkers and that sort of thing. There are some regimens that are specific to particular genes. There are stem cell regimens that are being tried in a controlled setting, not the out-of-pocket craziness that happens. And of course, always medications that we're looking into. So it's a complex disease. It's difficult to diagnose, also a challenge to manage. Our etiology and pathology are poorly understood. And there are sort of limited disease-modifying therapies available. The benefits of those are pretty minimal, and care is really best managed at a multidisciplinary clinic. Okay. Only 1 minute over, that's not bad.